presentation, Lita. Now, basic considerations before starting treatment in a glaucoma patient by Dr. Girija K. Madam is the head of the Department of Glaucoma Services, Little Flower Hospital.
So, basic considerations before starting treatment in a glaucoma patient. As you know, the elevated intraocular pressure is the only modifiable factor, and we try to reduce it to prevent progression of the glaucoma. So, a patient, a 55-year-old female, comes to you with an IOP of 28 in the right eye and 27 millimeters in the left eye. The CCT is in slightly thinner, 507 and 508. And the cupping, right eye shows a 0.8 cupping with superior and inferior thinning, and the left eye a 0.6 cup. So if you look at the field, there is superior aqueous scotoma in both the eyes, even though the left eye is showing only a 0.6 cupping. But the IOP is definitely high, and the OCT also is green. But since there is cupping and there is asymmetrical cupping, you can consider, and the IOP is high with this because we have repeated the fields 2 or 3 times and we got consistent results. So the diagnosis was a primary open angle glaucoma. So how to proceed in such a case? So first you establish the diagnosis, then you establish a baseline IOP by at least measuring once or at least twice or thrice, and then you set a target IOP. This target IOP has been the dogma that has been dominating the glaucoma world for several decades now, and it was reinforced by the post-hoc analysis of AGIS, which states that an IOP of 18 millimeters of mercury in all visits or an average IOP of 12.3 millimeters has halted the glaucoma progression in that large study. So this, it is assumed that the target IOP, if the patient is having target IOP, then the glaucoma will not progress, and if it is below target IOP, it's better, and if it's above, then the disease can progress. But this is not a magic number. You have to individualize and find out the target IOP for each and every patient. Always it should be individualized with an aim of preventing disease progression and also to not to affect the quality of life of the patient. So what are the factors you should consider? You should consider the age of the patient and the disease, the structural damage, the functional damage, and the baseline IOP at which the damage has occurred. And also consider the other additional risk factors like comorbidities and ocular diseases. So target IOP can be calculated by formulae, or there is the rule of thumb which states that mild disease requires 20% reduction, moderate 30%, and more than 40% in severe glaucoma. But one thing you have to be aware, the higher the IOP, the larger is the reduction required. That is, if the patient is coming to you with 60 IOP, then a 40% reduction is not enough. You have to bring it down to the normal level. And the target IOP actually doesn't consider the risk or the side effects. So what are the factors to consider before initiating treatment? So you have to find out whether the disease, what the disease is. That is it open angle glaucoma or a narrow angle glaucoma? And if it is open angle glaucoma, then straight away the first choice is medical treatment. And you have to stage the disease to start drug, because how much percentage of reduction you require, you have to decide. So you have to consider the patient factors. One is the age. Many of these topics that I am discussing may be previously discussed by Lita, so there may be some amount of overlap. Please excuse. The age is, if the patient is young and the patient is having an aggressive disease, then you have to start more percentage of reduction, so you have to start a prostaglandin analog. But if it is a younger patient, then less percentage of reduction is required, so you can wait and you can start a milder drug. Then in children and young adults, you may have to avoid certain group of drugs. So, and also consider the associated ocular diseases and other comorbidities, systemic comorbidities. Like beta blockers are absolutely contraindicated in COPD and heart block. But in cardiac failure, actually systemic beta blockers are given, and you can give topical beta blockers. Then prostaglandin analog, when you're starting, you have to, there are other considerations like pigmentation of the iris and pigmentation of the skin, especially when you want to start unilateral treatment. So these figures show the change of iris pigmentation, like the brownish eye, even the brown has become darker. So if you are starting in one eye, that may cosmetically, it may not be acceptable to the patient. So you have to explain it. The periocular pigmentation also, in fair skin people, if it is uniocular, better start some other drug. And always consider the compliance, because once daily dosage may be more acceptable, but twice or thrice daily may not be accepted by the patient. Then if there is any history of allergy, that also has to be kept in your mind. So how to choose the appropriate drug? This will be dealt in detail by Dr. Manju, but I'm just saying the important points. So find out the IOP lowering effect, whether you can reach the target IOP with this particular drug. So there are various drugs that are available. So always consider the efficacy, the compliance, and the safety profile. If the drug is cost effective and the dosage is convenient, compliance always improves. And the fixed drug combinations have always improved the compliance and cut down the costs. And another thing to consider is when systemic drugs are given, especially in beta blockers and carbonic anhydrase inhibitors, it can reduce the effectiveness of the topical drug. So better avoid giving them together. If there is no other option, you have to give. So the advantages of prostaglandin analog has already been discussed by Lita. So once daily dosage and the 30 to 35% IOP reduction makes it the first drug of choice. And it gives a diurnal and nocturnal IOP lowering. That makes it the superior drug. But it has got so many side effects which you have to consider. Except for that, it is free of systemic side effects and it can be tolerated by many. And the beta blockers, because of the systemic side effects, it has to be started with caution. And another thing to remember is the nocturnal lowering of IOP is actually very minimal for beta blockers. And especially the systemic side effects also you have to keep in mind, and always advise the patient about punctal occlusion. So this is a 78-year-old patient who was referred for management of neovascular glaucoma of the right eye. Patient was referred from another center. She was already started on Mysopt, and she was waiting in the waiting area and she collapsed in her OPD waiting area. So she was taken to the emergency and her BP was very low, 90/60, and heart rate was also 40 per minute. So there was a patient was taken to the emergency and ECG was taken. A sinus bradycardia was diagnosed, and the cardiologist has seen the patient was on systemic beta blockers. So it was stopped by the cardiologist. And the symptoms recurred again after stopping this thing. Patient went home, but again the patient had the same symptoms. So on close questioning, we got the information that it is happening after the Mysopt. And it was stopped and then patient got relieved. So you have to be aware that the systemic bioavailability of ophthalmic timolol is around 78%, and it reaches the circulation in 15 minutes. So that has to be kept in your mind. The 24-hour IOP control is much better for prostaglandins. And something else is adjunctive therapy. When you're combining prostaglandin with timolol or dorzolamide, you get a better effect. Especially with dorzolamide now the combination with dorzolamide is supposed to be superior than that with timolol, because PGA induces a carbonic anhydrase enzyme in the epithelial cells of the ciliary process, which can result in an increased ecosystem production, and this can be countered by the carbonic anhydrase inhibitor dorzolamide. So that combination is better than the other one. And concomitant use of pilocarpine and prostaglandin analogs may be mutually antagonistic. This is a 55-year-old female that I have, so that case was already discussed. So the patient was actually, because the IOP was 28 and 27, she was started on prostaglandin, trioprost, once daily, and the patient was on follow-up. The IOP came down to 21 and 19. So because the right eye was having cupping, brimoinidin was added. And the IOP came down to 16 and 15. Because she was having asthma, we couldn't add brimalol. But after 6 months, the patient came back with pain and redness, and she was having uveitis, severe uveitis, which did not resolve even after stopping trioprost. So instead of trioprost, we started dorzolamide and along with the uveitis management. But uveitis persisted. So only after stopping the brimoinidin, the uveitis resolved. So you should be aware that brimoinidin can cause granulomatous uveitis, and you have to keep that in mind. So management for each patient should be customized, and consider the patient as a whole, not the IOP alone, and while deciding on treatment, and choose the appropriate drug. Keep in mind the cost, dose, and the side effect, and reset the target IOP on follow-up visits. Thank you.
Thank you.